The topic of my presentation is the efficacy of recombinant LH supplementation for controlled ovarian stimulation in recombinant FSH and GnRH agonist protocols. When we study a new medication or a combination of medications or a new stimulation protocol, we always go back to the basics and we try to see what happens in the natural cycle, what regulatory forces control follicle development. We do this despite the fact that a stimulation is not a natural process. It's not a physiologic process because it is not normal for the ovary to produce several follicles at the same time. Now, said this, we always try to apply the basic rules to the stimulation as well. So a primordial follicle, to reach the ovulatory stage, it's a long journey. It takes about 3 months. Most of this development is regulated by growth factors produced locally, and gonadotropins, FSH and LH, become more important during the last 2 weeks of the folliculogenesis. When we use stimulation, we use in general two classes of medications. We try to induce multiple follicle development, so we need medications that will achieve this. But we also want to avoid premature LH surges and premature ovulation, so we need medications that prevent this. Now, both GnRH agonist and antagonist effectively block the pituitary LH and FSH release, and they result in very low serum LH levels during stimulation. The gonadotropins that we use are either pure FSH or LH preparations or contain various combinations of these two hormones. So if we want to study the efficacy of these hormones separately, then the patient with hypogonadal hypogonadism is a perfect clinical case for this because they produce minimal FSH and LH.